procurement of bedaquiline. And so it's a long process because, as you probably are aware, it's an extremely expensive medication. And meanwhile, the patient developed more neuropathy that neurology felt it was due to linezolid and cycloserine. We added gabapentin to the pyridoxine and hoped for the best. The patient was otherwise doing much better. His chest X-ray had improved. As you can see here, this is from July. And the small cavity, and I think I lost my pointer, but anyway, and there is a small tiny cavity on the lateral film, and you can barely see it in the PA X-ray. He still has some infiltrates, but it's way much better. And by July 18, his sputa was negative. We had 3 consecutive samples that were negative. So at that point, we contacted the homeowner and asked the homeowner to take the patient back because we needed to start the bedaquiline that was procured by our pharmacy only as an outpatient because of the price difference. However, the homeowner refused to take the patient back home, and it took a while for somebody to agree to house the patient, but not at that time. They had to wait until some home improvement were finished in that place to receive the patient. So again, he only has the 5 drugs that we mentioned before. In preparation for the bedaquiline, we got an EKG looking for the QT interval. And this is the baseline EKG. And you can see the patient has a first-degree AV block. And it has already a prolonged QT interval. So that was worrisome because we needed to add the bedaquiline, and he was already in a quinolone. So we were kind of worried about that. On September 9, he was able to be discharged to the friend's house, and then we started bedaquiline. We were able to switch levofloxacin to moxifloxacin, and the problem is that his neuropathy worsened, and he was falling, and we started physical therapy on him. Neurology felt that it was the drugs, the problem. All the workup we did was negative for any structural or CNS involvement. So we assumed it was basically the medication. And the thrombocytopenia and worsened. Actually, he developed pancytopenia. These are the labs. So now his platelets are again in the 90K range, and he now has decreased neutrophils and anemia. We were trying to reintroduce the injectable at that point, but his renal function never went back to normal. Even now, his renal function is not back to normal. So the new regimen was bedaquiline, moxifloxacin, cycloserine, pyrazinamide, and ethambutol. We had to stop the linezolid. It was stopped at the end of September. Now at this moment, he's still doing physical therapy, but he's able to ambulate without help. He's actually working now as he works as a driver. He's able to manage with the car without problem, and the dizziness has resolved. The EKG follow-up in October showed worsening of the QT interval, as you can see. He continues with the first-degree AV block. But we were monitoring very closely his electrolytes and his magnesium level. And this chest X-ray, which is the one we did last month, you can see is dramatically improved. Now the cavity has completely resolved. He still has some fibrosis that you can see in both X-rays, but has improved tremendously. And to our surprise, the EKG that we just did last month, although it still has the first-degree AV block, the QT interval is back to normal. It was even better than before. So that makes us feel so much better, and knowing that he's improving too. His laboratories, his platelet count now is back up to 145, okay, which is much better than, it's not back to normal, but it's much better than before. And the WBCs are back to normal now. Now we're going to jump the wheels, and we're going to talk about contact investigation. We contacted a homeowner, and she declined to come to us to be assessed. However, we were in contact with the PCP. It's actually an infectious disease doctor from UIC, University of Chicago. And she got a chest X-ray that was abnormal. We expected it because she has pulmonary fibrosis. Her first and second IGRA were negative, and we recommended to get sputa on her, and her smear and cultures are negative again. And obviously she's being followed by UIC and by us. And this is taking us to question number 5, which is management of multi-drug resistant contacts that have been diagnosed with LTBI. This time what we want to do is we want to select the wrong answer. So letter A says, when you have a patient with LTBI, and what is the right approach? We have to follow the patient for 2 years. B, treat infection control, contacts with at least 2 drugs that the index case is not to be susceptible. C, use a regimen that has a base quinolone included on that for 12 months. Or D, use rifampicin and isoniazid once weekly for 12 weeks.
So you have 11 answers up there?
Yeah, I think it's everybody is done, right?
I think so.
All right, great. And yeah, everybody got the right answer, which is true. You know, all A, B, and C are correct. D is obviously incorrect. Okay.
Well, is A, B, and C equally correct?
Well, this is a very good question. You know, to use a quinolone, we need to make sure that the patient is susceptible, right? So it's not really a blank check. It's not like that's the way it's supposed to be. Before we start treatment on these patients, we need to make sure that the drugs we're going to use are going to be appropriate. And that's what we actually were thinking in our patient. So the wife was in the contact investigation, the one that has latent tuberculosis now. She is asymptomatic. Her IGRA, obviously you can see, is positive. Her HIV test was non-reactive. So we knew that the index case was susceptible to quinolones. So we decided to use the 2 drugs that the patient is, the index case is susceptible, and start in the LTBI. This is her chest X-ray, which is completely normal, as you can see. And here, we were using this base, you know, in the Curry International Center. When they recommend, the quinolone plus ethambutol, the 2 drugs that we knew our index case was actually susceptible. But of course, that wouldn't be the choice if the index case was resistant to the quinolones. We decided to use this approach also based on this important paper published by the International Union. This is actually a report. This is an observational study, a report that comes from Micronesia, where 2 simultaneous MDR outbreaks happened from 2009 to 2012, where 119 contacts of patients with MDR were identified as having infection. In Micronesia, what they used two regimens that you can see here. One was the quinolone-based treatment and ethambutol for 12 months, or the quinolone plus ethionamide. In our patient, we decided to avoid ethionamide, and we used the ethambutol instead. We actually are following the same indications, the same follow-up the article was saying. So they were checking the patients every 3 months in Micronesia. They got a baseline chest X-ray, and then in 6, 12, 24, and 36 months. And treatment was defined as completion if they receive at least 80% of the doses on the DOT within 15 months. So from the 119 LTBI contacts that they assessed, 15 of them refused prophylactic treatment. And down the line, 3 of them developed multidrug-resistant tuberculosis. From the 104 patients that were treated for LTBI, even the patients that 11 of them that discontinued treatment down the line for many reasons, from pregnancy to side effects, etc., none of them developed multidrug resistant down the line. Some of the toxicity and side effects they found are actually depicted in this table, but actually our patient had no problems. Still, it's doing very well, and this is a chest X-ray that we just did last month, and it looks pretty good. All right, now we're going to switch gears a little bit here. We decided to talk a little bit about the new updated guidelines of the WHO. They just came up actually this past summer, and there are so many things that actually they discussed, but basically the most important thing they discussed was they are trying to find a combination, optimal combination regimen for patients with MDR and XDR, and also for treatment for Mycobacteria bovis. And which is very pertinent for all over the world and for us too, is the so-called SHORTER regimen, which is a regimen of multidrug resistant that is delivered within 12 months. And of course, the use of surgical intervention for the treatment of patients of multidrug resistant and XDR. So what is the SHORTER regimen? It's the one, as I said, that is delivered within 9 to 12 months. If they recommend to use the second-line drugs if they have not been used in the past, or we know that the patient is not resistant to them. That means the fluoroquinolone and the injectable. And the recommendation is to use at the beginning, in the intensive phase, at least 5 drugs. So in general, the intensive phase is when is considered when the injectable is used. And during the course of treatment, it's recommended to continue using pyrazinamide. To choose the drugs that are appropriate, they recommend to use 1 drug from group A, 1 drug from group B, 2 drugs from group C, and if you cannot use 2 drugs from group A, B, and C, at least to use 1 or 2 from group D. Now, let me show you what the groups are. These are the groups that are actually found on the for the WHO. Group A is actually the fluoroquinolones. Group B are all the injectables. Group C are the ethionamide, cycloserine, linezolid, and clofazimine. And group D are these other ones, but obviously you can see the bedaquiline and the lamanid are there. The reason why these drugs have been classified in this way, especially the daqualin and the lanamid, is not because they're bad drugs. It's because there are not that many randomized controlled trials yet. They are new drugs. Also, linezolid is being moved to the higher, classification of groups because it's been shown that it's an extremely effective medication for our patients, and that's why it's changed. And then in group E3, you have the carbapenems, imipenem and meropenem, that are meant to be used with amoxicillin aclobelinate. Amoxicillin per se is not really useful for tuberculosis, but it's a clavulinate that is actually added to the treatment, but it's difficult to find. I don't think it's available to find clavulinate alone, and that's why they're meant to be used together with augmentin. And if you ever saw the old classification for from the WHO, all the macrolides were taken out for treatment of regular tuberculosis, and they're just basically more for the non-tuberculosis mycobacterium. And I think with that, yeah, I think that's the last slide, and I'm open to any questions or any comments at this moment.
Thank you so much, Dr. Macias, for going through quite an interesting selection of issues pertaining to MDR-TB. We will open the line to questions from the audience. And you did list here a few topics for discussion, starting from tailoring a regimen for drug-resistant TB. So perhaps we could start with that as a point of discussion. Any questions?
I have a question.
Okay. Introduce yourself.
Hi, this is Patty Woods from the Global TB Institute. My question is with the contacts. You said, I guess if you didn't treat them, you would follow them for 2 years. And my question is,
right.
How often? How do you follow them? Like, how often would you have them? Do you have them come in?
So normally what we do is we do the baseline like everybody else's, right? You do your X-ray and your labs and all that at the beginning. And I normally, if the patient doesn't have any acute disease, a normal chest X-ray, no any chronic problem like diabetes, cancer, or is immunocompromised, then I follow the patient every 6 months for a total of 2 years. If a patient has any chronic disease that will make the person immunocompromised, then you follow those patients closely. If a patient has an abnormal chest X-ray, like in the example of our patient with pulmonary fibrosis, those patients really need to have a sputa to be sent to for culture. And it might be a good idea to repeat it later on as well in about 4 to 6 months. And obviously they need to be followed closely. If you prefer, you cannot treat them for whatever reason.
Great, thanks.
I'm sorry, about children, obviously, it depends on the age of the child, right? So you might need to see babies more frequently than, a older child, okay?
Thank you.
Lee has a comment.
Yeah, thanks very much. That was really an outstanding review and presentation. I would like to comment on the question that Patty just commented on. I think the problem with 2-year follow-up is maybe in your hands it gets done, but I think in most situations people sort of lose interest, patient loses interest, clinic forgets when 6 months is. I think 6 months follow-up is an excuse for not preventing secondary cases of MDR-TB. You cited correctly the BAMRA study that was published in the International in the Gray Journal, I happened to have a discussion with Dick Brostrom, who was one of the authors, for a presentation I gave, and I got follow-up numbers, and it's really remarkable that there were more cases and secondary cases in the people who didn't get MDR prophylaxis, but still, anybody who got any quinolone-containing regimen has not yet gotten a case of MDR-TB. Now, this problem with this is not a controlled clinical trial, and so people say, oh my God, we need controlled clinical trials. But by the time we get controlled clinical trials, a lot of people are going to die of secondary MDR-TB. So this is one of the situations where our community and many other communities are a slave to the grade system. You yourself mentioned the short regimen, which WHO, after being pushed and shoved for a long time, has adopted in special cases outside of the grade system, because there's still no, except one, there's no controlled clinical trials. There's some in process, but the short regimen is so painfully good that if we wait for the STREAM trial numbers to come in by 2018 or 2019, a lot of people will not have benefited by the short regimen. So we in our community and our decision makers and our leaders have to be ready to empirically do what we used to call expert opinion and do what's right for the patient, rather than say, oh, there are no clinical trials, we have to wait while people die.
Right, and you're absolutely right on that. That International Union.
I'm sorry.
I'm sorry. No. I was saying that you're absolutely right. That the WHO felt pressed by the International Union to recognize that these regimens, like the Bangladesh, I think was the original one, then the other ones in Africa, and some of these were actually short, like 9 months. And of course, 12 months is probably the right thing, but I'm not quite sure we know. But yeah, it's just the lack of, randomized controlled trials. That's the only thing. That's the only reason. But yeah, we have to do something for these people, because MDR and XDR is out there. It's in this country. And it's going to get worse, not better, because people are mobilizing more and there are more conflicts in the world. So yeah, I agree with you.
If I could just bring the case back to the patient himself. Nowadays, not only here in the U.S., globally, the move is towards this the NTB strategy, and really focusing on what we could do better for latent TB infection. And so I think this case itself is really descriptive of the kind of problems we see when we could probably have prevented some of this. Maybe not that this case is an MDR case, but we have a foreign-born patient who's been in the U.S. for a couple of decades, if I'm not mistaken, right?
Right. 16 years, and we were very surprised about that. Yes, you're absolutely. Yeah, that was an issue.
16 years, hasn't traveled, and is diabetic, and really all the parameters that would, at least in some sensitized circles, would say this is the kind of patient that I would like to screen and intervene for latent TB. So what was the, do you have any background on the kind of how well controlled the diabetes of this patient was? You have an A1C.
You mean the treatment in the Philippines?
No, the current A1C of the patient when he got sick. Do you have that information?
No, I don't remember. I don't have that.
Yeah. We were looking here in New Jersey to try to describe what patients with diabetes tend to have when they develop TB, and they tend to have worse X-rays, cavitary X-rays, and so I would be interested to see what this patient's A1C was, and they tend to be like above 8.
Right. That is a really important. You're right. That's a very important important issue. The one thing we found on this patient was that he has immigration problems in this country. And that's why he was living in this situation. So he didn't have really a good medical insurance or care. And the medications for his diabetes were given by friends. And his homeowner, the homeowner is, I had to report that he's also a doctor. So she used to give free samples to the patient. So I don't think the patient got a really good medical care. And yes, diabetes is probably the leading cause of immunocompromised situations in the world that is making tuberculosis another problem, not only in Latin America, but also in India. So I guess that's a big issue.
Right. So can I just bring the discussion to a little bit about tailoring drug regimens for MDR-TB and really how we manage side effects? I just wanted to emphasize your first couple of questions where the appropriate patients to do mutation screening were people who are from endemic countries for MDR, individuals who had prior treatment for TB and relapse here. I think those are the ones that we really need to kind of do the MDDR testing earlier rather than later, because sometimes information gets delayed 2 months, 3 months before we realize we're dealing with MDR-TB. So that was one point. And with regards to tailoring a regimen or starting quote unquote an empiric regimen, I really would call it empiric maybe if we don't have the drug susceptibility testing for second-line drugs, but I think it's fairly well guided if we have at least the mutation report, the panel of mutation testing that the CDC is able to provide. I'd be comfortable to start a tailored MDR regimen based on that, and that you might have within your first month of dealing with a patient. So.
Mm-hmm. Yeah, no, you're right. And in our hospital, we didn't have the capability of doing the rapid molecular testing. It had to be sent out to the state lab. And, it wasn't part of the protocol that we use in our hospital for any TB patient or suspect that comes through the door. And I think this has been a very good lesson for us.
Yes.
And right now our hospital has managed to acquire the Cepheid gene expert, and now all the patients that are suspects will immediately get a molecular testing for RPO mutation, which is just basically what you were saying. Those patients, especially coming from countries where MDR are prevalent, they need to be checked as soon as possible.
Importantly, the prior treatment history is really sort of one of those key red flags. And you had, as part of your choices, people who are going through a congregate setting, and that was interesting to me. I'm glad it's underlined there that if they're going through a congregate setting, consider testing, right? Was that part of that question? And go back to that.
Right.
Why is
Yeah.
that? Why is that?
The reason why, well, first of all, if the patient is going to go to in a case, a patient that had became suddenly homeless, and becoming homeless, then we were looking into a shelter for him. There is a tuberculosis residence that we have in Chicago for our homeless tuberculosis patients, and we were looking into trying to get a patient there. And of course, that was an issue. We don't really want to send anybody with TB, regardless if he's, it's MDR or not. We don't want to send any patient to a congregate facility if the patient is going to be infectious. And I understand, at least in Cook County, where we practice medicine, the correctional facilities are very good at screening all. If somebody gets arrested, you can immediately check for tuberculosis. The shelters here also are very good, and they work with us. So, we make sure. But regardless if it's MDR or XDR or, susceptible tuberculosis, no patient should be released to a place where there is a congregate setting, because the chances of infection will increase. So I guess this is will be a rule of thumb until we know that the patient has been deemed non-infectious. And again, going back to the question, when you said at the beginning that how long do we have to wait before we stop the isolation on these patients, and becomes very tricky, especially also if a patient is going to end up in a shelter. When is it time to send the patient back to the shelter if the smear is still positive? And as you mentioned it, patients that have capillary lesions or they have miliary TB, they tend to have positive smears for very, very long time, sometimes up to 12 weeks or even more. So these patients are difficult to keep them on isolation all the time. So that's when molecular testing becomes extremely important. Because if we assume that the patient is not resistant to rifampicin, we don't care about the isoniazid as much, but rifampicin, then even with the first-line treatment in the intensive phase, that will be a good regimen. If we just continue with all the drugs throughout the treatment without going to the continuation phase, just continue with all the drugs for the 6-9 months or whatever, that patient will be cured, even if the patient is resistant to isoniazid. We keep the 3 drugs. And if, the patient, as long as we know that there is no absorption problems and the drug levels are fine, the patient can be released without problem and wait until the cultures, until and see the smears might just clear later on without, being an infectious patient.
I would just like to, the fact that you raised this idea of molecular testing for those in congregate settings, I think I tend to support that because the impact is greater if you are in a correctional facility and have an undiagnosed MDR-TB circulating. We've had that happen here in New Jersey, and a lot of contacts that get released to the community without appropriate treatment, and it's impossible to track. So I think if the impact is great, then if it's available, really I would advocate at least GeneXpert. If you knew it's rifampin resistant early on, then you could do further testing. So this is, I think, something to emphasize. Patty has...
I think one other thing that is important when you're looking at getting people out of isolation, and I think that was one of your first questions, was not just looking at the negative smears, but you also have to look at, are they coughing? Because I know a lot of times, I used to get calls, or if you have a patient that can't produce, and they're in the hospital, how do you know when to get them off of isolation? And one of the first things we always want to know is, are they coughing? Because, that's another important element of getting off isolation.
Yeah, I think it's common sense. Sometimes some places call and ask me if they need to do a bronchoscopy because the patient can't cough, and I said that's really unnecessary. I think the absence of a cough is an indication that they're probably not infectious or not capable of transmitting. Anyway, we have one more question here. It seems many of our TB patients with diabetes 1 or 2 have, what is that, poor to no control of their diabetes. Yes, I agree. That was Barbara Williamson from, I think, Camden, right? Yeah. Yes, I think the idea of TB and diabetes is really one of those that interests me a lot, and is something that the TB community is trying to focus a little more on, as we have been taught over the last 10 years to integrate care for TB and HIV. I think over the next several years, the next level of discussion will be probably how do we integrate care for diabetes among our TB patients. And certainly with poor diabetes control, TB response is slowed down. And so there is benefit in ensuring good diabetes care while you're treating TB. So yes, I think there's more you'll hear about this as we move forward. Any other questions? Okay. Well, again, Dr. Masias, I think we're going to end this afternoon's conference. Thank you for participating. I guess now we could consider Chicago as part of the Northeast region. Is that?
Where we want to be.
Where is Chicago anyway? Oh, Illinois. Okay.
Illinois,
no,
yeah.
No, but feel free to reach out if you have anything interesting. Certainly, we have ARPITA that's willing to put you on the program. But again,
Sure.
Thank you for discussing, going through all these topics in the short 1 hour we had. And for everyone else on the line, thank you for participating. Go ahead, Dr. Masias.
No, I was just going to apologize for the technical difficulties I had this morning. You know how it is when the day is you're looking for and then things go wrong, right?
Yeah, it tends to do that when it's about to start. I just want to tell everyone on the line that the next meetings, next grand rounds, scheduled for January 20th, focuses on One Health. Francisco Palpica from the International Union will talk about the intersection of the environment, animal health, and human health, likely focusing on mycobacterial infections. And the following meeting on January 27th will be on M. bovis by Dr. Suli Rob Osserman. So I think we're focusing on the mycobacterial and environmental mycobacterial issues for January. So we hope to have all of you back after the holidays. And from the whole GTBI, we'd like to wish everyone a great holiday season and see you in the new year. Thank you.
All right. Thank you very much. Take care.
Bye-bye.